Hi, good morning and welcome. It's a privilege to be here. I genuinely enjoy working with the orthopedic section. Family members have enjoyed your expertise, and I'm certainly happy to make this a more integrated unit. So I'm Dr. Walter Wynkoop from Ocean Pulmonary, and this morning we're going to talk about preoperative and perioperative, postoperative pulmonary evaluation and management with a special emphasis on the orthopedic patient. By way of introduction, the purpose of this talk is to identify some of the postoperative pulmonary complications that we might expect or anticipate because they can add to not only mortality or death, but they can add to time in the hospital, discomfort for the patient, dissatisfaction for the patient, and increased resource use. But we know that we can, to a certain extent, anticipate some of these problems, prepare for them, and help to reduce their impact. So what are some of the postoperative pulmonary complications we need to think about and plan for and preempt? Probably one of the biggest ones and most common ones in the postoperative period is simply atelectasis. It's a word that's used a lot but may not have clear meaning for a lot of clinicians. Atelectasis is simply when the subsegmental airways collapse partially or completely, restricting airflow into those segments. And the problem is that just because there's no air going into those segments doesn't mean there's no blood. This creates what's called a ventilation perfusion mismatch. You have blood flowing through segments of lung that aren't getting air, therefore they're not getting oxygen and participating in gas exchange. So this can create hypoxemia and also lead to, number two, atelectasis can be a precursor to infection. If you have areas of the lung that are atelectatic, they're not moving air in and out well, they become a nice focus for potential infection. And certainly postoperative pneumonias are something we try to avoid. Other concerns and increased risk for infection are simply decreased sensorium. Narcotics, in addition to having direct impacts on ventilation and reducing ventilatory drive, they also can blunt your ability to cough and clear secretions. If we think about what is the probably most effective antitussive or cough medication, it's codeine, right? Well, all narcotics across the spectrum reduce that cough reflex. And when our cough reflex is reduced, you have increased secretions or decreased ability to clear secretions, increased risk for atelectasis, increased risk for pneumonia and infections. Respiratory failure and hypoxemia, certainly as a product of atelectasis or evolving infections, or difficulty clearing secretions, but they can also be a product of just postoperative positioning. If you're laying in bed, not as physiologic as being upright. We were designed by our creator to be upright probably most of the time, either in a sitting upright position or a standing upright position. And in the postoperative period, oftentimes that's not possible. So positioning can lead and add to potential for hypoxemia and respiratory failure, as can the medications that we naturally need and use in the postoperative period, again being narcotics and sometimes residual anesthetics and anxiolytics. In patients with asthma and COPD, they can sometimes see exacerbations triggered by atelectasis, retained secretions, direct product of anesthetic, etc. So this is something that we'll watch for as well. And then lastly, probably the topic that gets the most focus, particularly when we're dealing with orthopedic cases, is the concern for deep vein thrombosis and pulmonary embolism. So what are some risk factors that we can look for and identify? Some of these you'll look at them and you'll go, well, sure, that makes sense. Some of them, like I did when I re-reviewed this topic, are like, wow, that's interesting. That's not a risk factor at all. Age, according to the American College of Physicians review, is an independent risk factor for postoperative pulmonary complications. The older you get, the more likely you are to have postoperative pulmonary complications, such as prolonged mechanical ventilation, pneumonia, need for reintubation. Those are the big respiratory ones. If you're below 50, not a problem. If you're 50 to 60, about 1.5 times the standard risk for postoperative complications. If you're over 80, you're moving up past maybe 5 times above the baseline risk. So it's probably important to recognize that the baseline risk mercifully is pretty low. You know, you're talking, depending on which postoperative complication, you're talking about things that are down around, overall about 1 to 2%. So even so, if you're over 80 and you have a broken hip, you're probably still going to come out of that surgery getting it fixed 90% of the time without a problem. But it's important to recognize and be perhaps more vigilant in those patient populations. COPD overall is about a 2.5 times increased risk for reintubation, pneumonia, and prolonged mechanical ventilation after surgery. Naturally, this varies, though, across the spectrum, depending on whether or not you have mild, moderate, or severe COPD. Pretty logical if you have an oxygen-dependent COPDer who gets short of breath walking across the room, they're going to be at a higher risk than someone who has mild COPD, uses just an as-needed inhaler, and is able to live independently. One of the interesting ones is asthma. If you simply have asthma, but it's well controlled, asthma by itself is not an independent risk factor by itself. So when I see patients in the preoperative period who maybe come to see me before elective surgery and they have asthma, and I clear them, I just remind them, don't be a hero. If you're getting a cold, if you're having an asthma exacerbation because of change of weather or whatever, just hit the pause button, reschedule that surgery. It's not worth the increased risk. Smoking by itself will increase risk for postoperative pulmonary complications by about 1.7 times over baseline, and that's in active smokers. One of the interesting things about smoking is that if you're going to stop smoking before surgery, it's best to do it greater than 4 weeks before your surgical period. There's some literature to suggest, although this is debatable, that you actually have an increased risk of postoperative pulmonary complications if you stop smoking within 1 to 2 weeks of surgery. And the theory behind that is that in active smokers, if you dive down into their bronchial tree, you're going to see that they burned out and are missing all of those cilia, all those epithelial lining cells with the little hairs that are designed to mobilize and move secretions and sweep everything up and help you spit it out. Smokers are actually missing those. It's like a burnout forest down there. And in that period when you first stop smoking, and you'll often hear smokers talk about this, for the first week or 2 or 3 that they stop smoking, they feel worse. They have increased cough. They have increased congestion. And that's thought to be the rationale for that. So if you have somebody that's only a week or 2 away from surgery and they're an active smoker, unfortunately, it's not the time to actually suggest that they stop smoking then. But if you see them more than a month away from surgery, definitely encourage them to quit smoking preoperatively. Obesity by itself is not a risk factor unless it overlaps with other issues. If you have obesity plus COPD, if you have obesity plus obstructive sleep apnea, or if you have obesity with other evidence of hypoventilation, then obesity becomes a risk factor. Signs that you can look for hypoventilation in obese patients are, for example, slightly reduced oxygenation. If instead of the normal 96, 97, 98, 99% room air pulse ox, you have maybe 92, 93, 94, and you have no other history of lung disease like COPD or anything, that might be someone that you think about screening for hypoventilation. Other tip-offs that you might actually have some chronic hypoventilation is an elevated serum bicarbonate. If you look at your preoperative basic metabolic panel and your serum bicarb is elevated above the normal, that could be a sign that they're compensating for chronic hypoventilation, and with chronic hypoventilation, chronic hypercapnia. So your serum bicarb is the body's natural balance to increase CO2 levels. So if your body has adapted to chronic hypoventilation and your carbon dioxide level, instead of the normal 35 to 45 range, is actually 55 or 60, you're going to see the body's natural compensation for CO2, which is an acid. You're going to see that natural compensation in an elevated bicarbonate. Your kidneys are going to correct for that and respond to that over time and adjust for that to balance that out. And so you may see on a basic metabolic panel an elevated bicarbonate. Pulmonary hypertension curiously had special identifiable risk for patients undergoing orthopedic surgery, particularly hip and knees. So if you get a patient that has a history of pulmonary hypertension, those are someone that may need particular attention in the perioperative period. Their risk factors can be, upwards of 4 or 5 times higher than baseline in the presence of pulmonary hypertension. If you don't have a history of pulmonary hypertension that you know about, when you're examining your patient, signs and symptoms of pulmonary hypertension that you could look for, chronic lower extremity edema certainly would be something that you would see. Talking to your patients and finding out that they get short of breath with activity without any other obvious reason for it, like asthma or COPD. Or if they have on their preoperative EKG, if they have signs of right ventricular strain, like a right bundle branch block, right axis deviation, maybe P pulmonale, which is when your P wave is particularly accentuated or peaked. Those are signs and symptoms that you may have pulmonary hypertension that's undiagnosed that might deserve a little further exploration preoperatively. Congestive heart failure, a lot like is sort of between asthma and COPD. Congestive heart failure, if it's chronic, compensated, really very little risk. It also depends on whether or not it's diastolic or systolic, although the literature doesn't define it or spread it out very well that way. Chronic compensated diastolic heart failure, where your ejection fraction is preserved, is going to behave a little bit differently than someone with chronic systolic congestive heart failure, where their ejection fraction is low, like in the neighborhood of 20, 30, 40%. So just being aware of congestive heart failure as an additional risk factor for not only heart problems, but also in this case, as for this talk, respiratory complications from fluid shifts, decompensated congestive heart failure, and increased associated hypoxemia. Albumin less than 3, likely as albumin can be not only a marker of overall nutritional status, with hypoalbuminemia reflecting perhaps decreased protein stores and decreased nutritional status, but it can also be a marker of chronic systemic disease. The body's very smart. If you've got a chronic systemic problem going on, body says, okay, I don't need to make so much albumin, I'm working over here. And so you can oftentimes see low albumin in patients that have chronic active disease processes or are malnutrition. And then renal insufficiency can be an additional risk factor. So what are the procedural risk factors? Well, the surgical site, and this probably makes sense, anything that affects the pulmonary mechanics directly, such as thoracoabdominal surgery, likely going to have more impact than if you're having foot, ankle, knee, or even hip surgery. The one orthopedic particular exception to this would naturally be spine surgery or even shoulder surgery. Shoulder surgery, overall, not a direct impact, but occasionally we see, and perhaps you've seen in this room as well, occasionally we see that when we get a nice shoulder block, a nice regional block for shoulder, and they do a scaling block or whatever, sometimes that anesthetic gets in there and hits your phrenic nerve, and then your phrenic nerve is numb and paralyzed for a while, and you're operating off only one diaphragm until that block wears off. So that's the one sort of special exception for shoulder surgery that you just need to be aware of. If you have a regional block for shoulder surgery, think about, and if you see a patient in the postoperative period, it just seems more hypoxemic than they should be or that they would have been expected to be, take a good listen and see if you hear normal breath sounds on both sides, or if one side is perhaps not moving air quite as well as the other. Duration of surgery, probably not a lot of surgeries go beyond 3 or 4 hours, but certainly the longer the surgery, the more incidence of postoperative pulmonary complications. As far as general anesthesia risk, general anesthesia typically has more postoperative pulmonary complications than epidural and spinal, which has more complications than regional. So whenever possible, if you can move in the direction of an epidural or regional block, that may be better for your patient as far as reducing pulmonary risk. So particularly in our patients who we have known moderate or severe COPD, or we have other chronic respiratory impairment preoperatively, if we can use epidural or spinal anesthesia instead of general anesthesia, their pulmonary risk tends to be a little lower. So what kind of testing and evaluation should we do in the preoperative period to help get a sense of what our risk might be? Pulmonary function testing, if you have no known history of lung disease, you're not impaired, routine pulmonary function testing is not recommended. So it just does not help. So if you have a history of someone who's perhaps an active smoker or former smoker, but they actually have no physical impairment, no physical limitation, preoperative pulmonary function testing has not been shown to be useful in that category. If you have someone who has known COPD, or if you're not sure whether or not their asthma is under control, those might be patients in whom pulmonary function testing would be suggested. But if you have someone who is asymptomatic as just a screening tool, again, not recommended. Similarly, chest X-ray. Chest X-ray seems to be sort of the standard of care for a lot of surgeries. But if you have people who are asymptomatic going for routine surgery, it's really unlikely to change management. If this is a surgery that you need, it's really unlikely to change management. So chest X-rays really are done, or really should be done, if you have a concern based on your history or physical examination. Right. The one caveat to that I might add, though, is if you have somebody who, let's say you're thinking about doing an elective, an elective knee or elective hip or some sort of elective surgery. If you have an older person who perhaps has been a smoker for a long time and they're in their 70s, and you're concerned about the possibility of, and they have not yet been screened, which they should be, for lung cancer, may be reasonable to just do that as not a chest X-ray, but to discuss and talk with them or their pulmonologist about a screening CT for lung cancer, because you'd hate to do an elective surgery only to find out a week or a month later that they have metastatic cancer that's going to be more pressing. But for most people, a routine chest X-ray is unlikely to change management. A 6-minute walk test, again, not routinely done. If you have patients that have known or suspected lung disease, a 6-minute walk test can be useful. A simpler version of that I use in my office, though, rather than a 6-minute walk test, is just asking them if they're able to do their activities of daily living without stopping, without getting short of breath, and if they're able to walk on a flat surface unlimited, essentially. If you're able to walk a significant distance on a flat surface without stopping, then you're likely going to do just fine with anesthesia in the perioperative period. The one challenge that oftentimes happens, though, is we get these patients who have a really bad knee or have a really bad hip. Kind of hard to do a 6-minute walk test anyway sometimes. Arterial blood gas, again, not routinely done. The only reason to consider doing an arterial blood gas is if you have a patient who, again, you have other reasons to suspect that they may be chronically hypercapic or hypoxemic. Again, a moderate or severe COPD patient, perhaps overlapping with morbid obesity, perhaps overlapping with severe kyphoscoliosis, which can create a restrictive defect to ventilation. These would be our patients that you might think about getting an arterial blood gas, not to necessarily delay their surgery or change the surgery as long as it's compensated, but to monitor them more closely in the perioperative and postoperative period, monitoring perhaps with continuous pulse oximetry or even a postoperative arterial blood gas to exclude the possibility that their chronic hypercapnia is getting worse in the face of being bedbound, being on narcotics, etc. One of the simplest sources of preoperative risk is one that our anesthesia colleagues use regularly, and it's a remarkably simple tool. And if you had to sort of pick one preoperative risk assessment tool, this is probably the one to just look at. It's the one our anesthesia colleagues use, and it's very logical. If you have an ASA category greater than 2, you're at increased risk. If you're a 1 or a 2, you're fine. So what's a 1? 1 is someone's healthy, getting an elective surgery, has no other medical problems. 2, mild disease like known hypertension that's controlled, diabetes that's controlled, asthma that's controlled. ASA category 3, things start to get a little bit worse. Perhaps you have chronic stable angina, poorly controlled diabetes, morbid obesity, those types of more significant systemic diseases. ASA category 4 is uncontrolled angina, uncontrolled diabetes, advanced kidney disease, advanced lung disease, advanced liver disease, etc. ASA category 5 probably don't have a whole lot of those in orthopedics, but those are your moribund patients that come in and they're going to die if they don't get surgery. That might be a ruptured aortic aneurysm, something of that sort. I guess multiple traumas, if y'all go up to Jersey Shore, might be someone that you'd be involved in that's got to go to the operating room, and without that life-saving surgery, they're going to die. And then ASA category 6 is by itself. They're organ donors. You know, they're people who, by design, are not going to do well postoperatively. Obstructive sleep apnea, I wanted to sort of carve this out into really its own category. Obstructive sleep apnea certainly is a risk factor for postoperative pulmonary complications. So just a little background. What is obstructive sleep apnea? Obstructive sleep apnea is a recurrent collapse of the upper airway, the pharynx, during sleep. We grade sleep apnea as an outpatient as far as how many times this happens per hour. Normal is less than 5. So the occasional snort and gasp, as long as you have no other signs or symptoms of sleep apnea, like excessive daytime sleepiness, frequent urination at nighttime, frequent nocturnal arousals, bed partner who looks at you and says, you know, you stop breathing a lot at nighttime. As long as you don't have those are some of the other risk factors that we'll talk about in the stop bang screening tool below. But a recurrent collapse of the pharynx not only restricts airflow, but it's important to recognize that it also restricts oxygen therapy. So in the postoperative period, you may be giving your patient supplemental oxygen, but if they have bad sleep apnea, they're not going to get it. And we can see this in the sleep lab. You'll see patients that have moderate or severe sleep apnea where their oxygenation is going down despite supplemental oxygen. And it can actually go down quite dramatically. Obstructive sleep apnea, if you have it, increases risk depending on the severity of sleep apnea by about 2 to 4 times over baseline for postoperative pulmonary complications, particularly recurrent intubation, prolonged mechanical intubation, and hypoxemia. One of the challenges with obstructive sleep apnea is if you've ever watched somebody else, because we don't do this, but if you've ever watched somebody else who uses who perhaps maybe has a few too many drinks and they snore more loudly. Things that relax our upper airway, like alcohol, like narcotics, like sedatives, make sleep apnea worse. So that's why they're particularly problematic in the postoperative period. Position therapy is one of the things that we use to treat obstructive sleep apnea. We know that obstructive sleep apnea is worse on your back for most patients with sleep apnea and better on your side, or better when you're sleeping on your belly, or better with the head of your bed elevated. And a lot of patients will do this instinctively. I'll see patients in my office who are coming to see me for the first time for evaluation of sleep apnea because they used to be a side sleeper and then they had rotator cuff surgery and now they're sleeping on their back. So we know that position makes a difference in obstructive sleep apnea, and positioning naturally postoperatively is usually on your back and perhaps in a more supine position, at least initially. So if we have known obstructive sleep apnea, we know to prepare for that and to think about it and to treat it during the perioperative period. What if you have somebody that comes in for surgery and they don't know if they have obstructive sleep apnea? What simple tool can we use to screen them for obstructive sleep apnea to see if we need to think about this during the perioperative period and plan for it? Well, the stop bang tool has actually been found to be remarkably sensitive and specific for picking out severe and probably more clinically significant moderate obstructive sleep apnea. Stop bang, STOP-BANG, stands for snoring, tiredness, observed apneas, blood pressure, age greater than 50, neck circumference greater than 16 inches in women, 17 inches in men, and gender, because men are more likely to have sleep apnea than women. With that score, you just give each one a 1 or a 0, and you add it up. If you have a score greater than 4, you're at risk for having significant sleep apnea that can impact you in the perioperative period. The nurses on the floor now are screening for that, so you may see this stop bang questionnaire at the bottom. Usually I think of the vital signs at the very bottom row near there. You'll see a stop bang assessment, and anesthesia oftentimes will be screening for this in the anesthesia suite. If you have obstructive sleep apnea, it doesn't mean you can't have surgery. It just means you need to think about it in the postoperative period and be aware of the possibility of prolonged mechanical ventilation or concern for reintubation in the postoperative period. If you have a patient who has known obstructive sleep apnea, we'll tell our patients to actually bring their CPAP or their BiPAP with them so that they can use it even in the recovery room and certainly beyond. If you have someone that you're concerned about the possibility of sleep apnea because they did poorly on their stop bang questionnaire, had a score of greater than 4, those are someone that in the recovery room and certainly beyond need to be monitored for the possibility of sleep apnea, and maybe think about getting pulmonary evaluation to see if preemptive BiPAP at nighttime or in the recovery room might be useful to reduce the risk for postoperative reintubation. Talking to some of your colleagues, there was also a request to just do some basic radiology review. So that's going to be the next focus of our talk. So let's start with a normal chest X-ray. And my apologies to those of you who can't see this but are on audio only. But a normal preoperative chest X-ray, a normal chest X-ray evaluation, you want to get into a habit, just like you do, I'm sure, looking at orthopedic films. You want to get in a habit of looking at the film in a logical way, so that your brain gets used to going through it in routine, sort of like a pre-flight checklist, where you just go through it systematically to look at things in order. I cut the name off of this patient, but naturally, number one is you want to look at the name and make sure it matches the film that you're looking at. Then after that, you go through a motion of just looking at, as we're looking at a chest X-ray, looking at You can do it in whatever order you want. You can look at soft tissues, then bones, then lungs, then cardiac silhouette, and upper abdominal structures. Just whatever method works for you is just get in the habit of looking at the X-ray that way. If we look first at soft tissues and bones, this is a normal chest X-ray, nothing to review there. As we look at the lung markings, this X-ray actually, when I made the slide, unfortunately got cut off at the top, but you want to be able to see the entire lung field. You want to make sure that you have lung markings all the way out to the edge of the ribs. You want to make sure that you have a sharp costophrenic angle where the diaphragm meets the ribs laterally. Should be a nice, almost V-shaped angle there, a nice acute angle. You should be able to see distinctly the diaphragmatic border. You should be able to see distinctly the right heart border. You should be able to see distinctly the aorta coming down. You should be able to see distinctly the left heart border and the left diaphragmatic border. So when we're reviewing for lungs, we want to make sure that we see all of these areas cleanly. Naturally, if you have pneumonia, you won't see one of these. Margins distinctly. You might see an obscured heart border. You might see an obscured diaphragmatic border. If you have pleural effusions, you might see the costophrenic angle not be sharp. Remember that pleural effusion is fluid, and in most of these upright films, that fluid's going to fall to the bottom. So you're going to see what looks like a meniscus, just that slightly up-shaped curve in a glass, where it may fill, of course, the lowest part. So you'll see it in this costophrenic angle, and it'll usually be a little bit upturned toward the rib side. So that would be a sign of pleural effusion on a chest X-ray. And certainly pleural effusions can get, quite large and sometimes encompass the entire chest. So brought a couple of examples of abnormal chest X-ray. This is probably a particularly horrible example. This is a particularly horrible example of congestive heart failure, and not quite as clean up here as it is on the computer, but if you look at a chest X-ray with congestive heart failure, the things that you're going to see, the things that you're going to look for, is you're going to see cardiomegaly. How do we define cardiomegaly in very simple terms? The cardiac silhouette, if you measure the diameter of the heart at its greatest margin, it should be less than half the diameter of your thorax. So if you go up to an X-ray just with your fingers and you're able to say, okay, here's the cardiac silhouette, that's clearly more than half the diameter of the chest, we have cardiomegaly. What is congestive heart failure radiographically? I like to think about congestive heart failure as a floodplain in the Mississippi. Think about, normally you should just have these nice little rivers and streams going out there that you can see those markings on a normal chest X-ray. In congestive heart failure, it looks just like that floodplain, during flood stage. Everything's moving upstream, so you'll see what's called cephalization. You'll see flow up toward the apices of the lungs, even in an upright chest X-ray. And you'll see this blurring, which you can imagine is just sort of flooding of the fields out here in the more central regions. So it spreads from the middle and lower to the outer and upper. This was just a nice simple example of what pneumonia might look like on a chest X-ray. A singular infiltrate in the middle of the right upper lung field. Again, here you lost the ability to see the lung markings going all the way out to the rib. Just a nice, simple, radio-opaque, dense area on a chest X-ray. I'll give, if we're going to go back over chest X-rays, we'll do that in the question and answer section at the end. So what are some post-operative preventive strategies we can use now that we've identified some of our risk factors for post-operative complications? What are some preventive measures we can use to reduce this risk? Certainly deep venous thrombosis and pulmonary embolism risk should always be at the top of our list and top of our consideration. And there's lots of great guidelines on how to reduce this risk. So I won't belabor that point. Incentive spirometry, though, as we look for ways to reduce problems with hypoxemia, atelectasis, pneumonia, incentive spirometry is actually ridiculously good at preventing pneumonia in the postoperative period. Early ambulation, I guess it's actually in orthopedics now. The goal is to discharge people even before they're extubated, I think is now the goal. So early ambulation, obviously something I don't have to preach here, but early ambulation for patients in the postoperative period certainly helps. Again, the quicker we can get people upright using gravity to drag the diaphragm down and get them up and moving around is going to be helpful. Narcotics and benzodiazepines, certainly oftentimes necessary, but just remembering that as with most patients, we want to use the least amount possible, and whenever possible, use perhaps non-narcotic medications, particularly in patients who were concerned about having some other respiratory impairment like COPD, sleep apnea, morbid obesity, overlapping with those things. Again, if patients have obstructive sleep apnea, telling them to bring their CPAP and BiPAP with them and to use it in the postoperative period. Or if we have somebody who has unknown sleep apnea who failed their stop bang, consider using that in the postoperative period or having it on standby. The one caveat I might add right here is one of the contraindications for the use of CPAP or BiPAP is nausea and vomiting. You might imagine if you have a mask covering your nose and mouth, not something good to use if you're vomiting. So, if you have some postoperative nausea and vomiting from anesthesia or whatever, unfortunately not a time that we're able to use our CPAP or BiPAP. So in conclusion, pulmonary complications are common, but we can screen for them. We can help predict them, and we can take steps to help reduce their impact and make our patients stay here a lot less eventful and get them home happy and healthy and quicker. At that point, I'd like to thank you for this opportunity, and I'll open it up to any questions you may have.
Really great. That was spot on. I think what we needed in terms of kind of the quick and dirty review. I want to go back to the screening for smokers because I think a lot of times we have this kind of standard panel, and I'm right. Believe it or not, it's probably the surgical coordinator who's checking all this stuff off, and chest X-ray a lot of times is one of those things. My question to you is the chest X-ray the right screening tool to rule out cancer in a smoker? Or is it, look, if you're more than 10 years smoker, whatever that arbitrary number is, you send them for a CAT scan instead? Has the CAT scan replaced the chest X-ray in terms of really diagnosing that?
Right. I mean, that's a great question. Again, the routine use of a chest X-ray, a lot of debate on whether or not it's even necessary or helpful in an asymptomatic patient. So it's really, this is the difference between, for a plain chest X-ray, this is the difference between, what's proved in the literature and what is sort of the de facto standard of care. So there's a lot of debate as far as whether or not to get a chest X-ray, and you couldn't be faulted, either way. Specifically, when it comes to concern for lung cancer in a smoker, the data that just came out a couple of years ago and led to a change in how we screen people for lung cancer really came down to what we call your pack-year smoking history. And pack-year is determined by how many packs per day for how many years. So if you're a 1-pack-a-day smoker for 30 years, that's a 30-pack year. If you're a 2-pack-a-day smoker for 15 years, that's a 30-pack year. It's that simple math. And what we found is that patients who have a greater than 30-pack-year smoking history and are over the age of 55 are the patients that we should be considering to screen with a low-dose non-contrast CAT scan of the chest for lung cancer. So greater than 30 pack years, over 55, annual screening, low-dose CT. Chest X-ray has never been proved to save lives, so it does not help in that regard. So it really has moved on to be a low-dose annual CAT scan of the chest, which Medicare pays for up to the age of 78.
The other thing is to stop banging. We're trying to get that
Mm-hmm.
part of the preoperative assessment in our office,
Mm-hmm.
figuring that, to verify.
And I'm glad that you brought that up because I actually forgot a very important point there. And that is, when we look at our, when we get patients in our office for bariatric surgery preoperative, obviously there's a concern there for obstructive sleep apnea. The literature in that population, and to a lesser extent in other populations, shows that if you're able to diagnose and treat obstructive sleep apnea preoperatively, their postoperative risk is a little bit lower. Not humongous, but it's a little bit lower. So, if you're seeing somebody and you're planning for, a preoperative hip or knee and someone who's morbidly obese, over 50 years old, particularly if they're male, those are someone that we may want to screen for obstructive sleep apnea preoperatively, because if you can treat it, they do a little bit better in the postoperative period. And screening for sleep apnea these days is so easy. You can do it in the comfort of your own home. As long as you don't have uncontrolled congestive heart failure or severe COPD, for the most part, about 90 to 95% of people that have a concern for obstructive sleep apnea can be screened at home. And certainly this institution, our office, Shore Pulmonary's office, everybody has at-home testing equipment, so we can get it done pretty efficiently.
That stop bang score available to us? You said the secretary to fill it out?
Yeah, we're trying to figure out how to do it, and I talked to Bob about it. He said that to do it at the pre-op visit, it's too late because.
Well, at least we know if they have greater than 4, then we can get home involved and consult them, in the post-op report.
Right, but I think you'd rather meet. I had thought meet with them before, before they get a BiPAP thrown on them, right? I mean, untreated sleep apnea, then the risk is still higher as they come into the hospital.
It's a little bit higher. We would really probably never stop surgery just for that, but we would want to be aware of it and then maybe make orders for possible use of BiPAP. CPAP stands for continuous positive airway pressure. And CPAP for obstructive sleep apnea, there's 2 ways you can go about it. You can use what's called an auto-titrating CPAP, remarkable piece of equipment that actually senses breath to breath whether you're moving the right amount of air. It learns your body and says, okay, this is the normal amount of air. And then when it starts to see obstructive sleep apnea, it actually ramps up pressure within a range that you set until airflow is reestablished. That's called auto-titrating CPAP. Very cool. We don't have that here. Most hospitals don't have that. But as an outpatient, we prescribe this all the time. Otherwise, it's set for a particular pressure. So really, as a pulmonologist, most of us would really just order BiPAP, because BiPAP sort of gives you a little bit of cover. You put sort of a lower constant pressure. That's what BiPAP is. Stands for bilevel positive airway pressure. So you have constant lower pressure. You'll often see numbers like, let's say 12/5 is a common initial setting. That means that your constant pressure is 5 centimeters of water pressure. Again, trying to help keep that pharynx open. And then the higher number is actually whenever the BiPAP machine senses you're taking a breath, it ramps up pressure just for that inspiratory time up to whatever else you set it for, like 12. And BiPAP actually, if you don't know what settings your patient with sleep apnea has, or if you haven't actually gone through the process of figuring out how to best treat a patient's sleep apnea, BiPAP is the tool that we use the most because it gives you more flexibility.
No, I mean, I think it's something.
But
I'm just
picturing.
like meaningful use kind of stuff that we're supposed to use. I mean, we take like smoking data, or we should. I mean, I don't know how we do this because we don't really ever have the MA ask that kind of stuff.
Right.
But like, why can't that be a screen that an MA does on a first visit?
great point. I mean, and like Dr. Estier, our pain guy has separate questions.
Yeah.
A new total joint patient that, we don't know if it's total joint, but we're assuming a new patient that seems Roderick's or Bogdan gets that questionnaire.
But even any patient that could potentially be a surgical candidate, just even for like, something outpatient, or spine, like, I think any new patient, I mean, we have to meet those criteria for Medicare.
I think it's a great idea. I mean, get it right on our intake form, and the EMR could probably calculate it for you, so as you quickly glance at that patient's record, you can see stop bang score 6, and that might trigger a red flag. Are we going to inundate you with consults if we start doing this now?
We're happy to accommodate that. It's and I'm sure our colleagues, because we have great respect for sure as well. But if everybody these days tends to have a little bit of a waiting list, but if it's something that's going to hold up your surgery, just pick up the phone and call us, because sleep apnea is the easiest thing we do all day. You can do a sleep apnea consult in about 15 minutes.
Back to chest X-ray. What about these routine preoperative chest X-rays? Are you saying not to get them at all? Like, is there an age limit if say they have hypertension, diabetes?
There's really not. Again, this is sort of the art of medicine. There's not great data to guide us as far as routine chest X-rays. The take home really is, if you have an asymptomatic patient, pulmonary wise, you have an asymptomatic patient who's going for routine surgery, you don't need a chest X-ray.
When they come to the ER,
if they came through the ER, they probably already had a chest X-ray and a CAT scan of their head and maybe a CT
It's probably not indicated. I mean, when we start looking at costs and bundles and things like that.
Well, that's right.
What's that?
the criteria is here, but it's non-elective cases. Over 50, smoker, under 50.
Yeah, you wonder where those criteria were made and what the evidence is behind it.
And when they get to surgery, they'll chest X-ray and anesthesia looks at us and says that.
And that's actually the difference. There's a difference between anesthesia literature and the pulmonary literature. And that's fine. I mean, chest X-ray actually, in the grand scheme of things, chest X-ray is pretty cheap. And not a lot of radiation. You get, last I checked, I think it's, you get about the same radiation from a chest X-ray as you do flying from New York to San Francisco and back 4 times. It's not a lot of radiation, but.
Good. Thank you.
Hey, it was my pleasure. Thank you for inviting me.